Hey, what's up, guys? This is Sasog Med. Today I'm going to be talking about sepsis, one of the most important concepts to understand in internal medicine. So, let's get right into it. So, sepsis, defined as life-threatening organ dysfunction from dysregulated host response to infection. The most important thing to remember in this sentence is that it's dysregulated. This differentiates it from SIRS, which is a appropriate host response to suspected infection. So, to diagnose sepsis, a quick rapid screening test is QSOFA, which is a 3-variable bedside screening tool that can be used to identify if a patient has sepsis. The 3 criteria are 1. Respiratory rate greater than 22, 2. Altered mental status, 3. Systolic blood pressure less than or equal to 100. If you have a QSOFA score greater than or equal to 2, you most likely have sepsis. There are other criteria in the extended SOFA, which includes PaO2, FiO2, platelets, bilirubin, blood pressure, Glasgow Coma Scale, creatinine, and urine output. The more criteria that you have that are abnormal, the more likely that is you have sepsis. So the guidelines recommend against QSOFA versus other screening tools for sepsis and septic shock. So septic shock is sepsis plus the use of a pressor to sustain the mean arterial pressure greater than 65 and lactate greater than 2 without hypovolemia. So, SIRS plus an infectious source is not sensitive for sepsis. So, I've already stated that. So, let's get into the pathophysiology and clinical manifestations of sepsis. So, when microbial components bind immune cells, this leads to an increase in inflammatory mediators and polymorphonuclear migration. If this exceeds the boundaries of the local environment, this leads to sepsis, which is a generalized inflammatory response that then leads to tissue ischemia due to thrombosis in the microcirculation, secondary to altered coagulability, leading to decreased RBC deformability and decreased O2 extraction. And this can lead to cytopathic injury, leading to mitochondrial dysfunction, and impaired endothelial barrier, leading to edema and further organ dysfunction. Let me explain this in simple terms. So, you have bacteria in a local site. When they spread to the peripheral circulation, it becomes disseminated. When it becomes disseminated, your body has a dysregulated response because the neutrophils will have to follow the bacteria wherever it goes. And this inflammation can lead to peripheral vasodilation of your arterioles, leading to third spacing. And when the third spacing happens, you get edema and further organ dysfunction. So, what are the signs of end organ damage? So, the cardiovascular manifestations are vasodilation leading to hypotension. Ventricular function may either be hyperdynamic or depressed. Why is this? This is because your heart is working harder to push the fluid through your arteries, despite the fact that it's leaking into your third spaces. So pulmonary manifestations such as pulmonary edema and ARDS, GI manifestations such as increased intestinal permeability, leading to increased bacterial translocation, leading to worsening systemic inflammation. Then you have hepatic manifestations such as cholestasis, impaired reticuloendothelial function. And then you have renal manifestations such as AKI of multifactorial etiology, including microvascular dysfunction, oxidative stress, and global hyperperfusion. Hematologic manifestations include early inflammation, late immunosuppression, procoagulant and anticoagulant disequilibrium, DIC, and decreased platelets. Endocrine manifestations include altered glycemic control, adrenal dysfunction, sick euthyroid syndrome. Neurologic manifestations include encephalopathy. So let us talk about the initial management of sepsis. So sepsis and septic shock are medical emergencies, so early recognition is critical. The components of initial management include, number 1, antibiotics. Administer empiric broad-spectrum IV antibiotics, ideally within 1 hour of recognition. Order them stat. Delaying leads to increased mortality by 7.6% by hour. More rapid antibiotics leads to decreased mortality and is much more important than fluids. For selection of antibiotics, this is guided by the infection site, prior microorganisms, community resistance patterns, exposures such as skilled nursing facility, lines, history of antibiotics, and host immunity. Consider double coverage for gram-negative organisms if severe sepsis and septic shock and high suspicion and risk for resistant organisms, such as neutropenic or burn patients. Usually, a beta-lactam plus a fluoroquinolone or aminoglycoside will be enough. For ESBL organisms and non-GU infections, carbapenems are preferred to piptazo despite microorganism sensitivity. If there's suspicion of toxic shock syndrome, add clindamycin or linezolid for antitoxin effect. This has more staph and strep coverage. If there are risk factors for invasive candida infection, such as neutropenia, chemotherapy, transplant, indwelling catheters, total parental nutrition, recent major surgery, especially abdominal, or prolonged admission in antibiotics, consider empiric antifungals, typically mycofungin. For beta-lactam administration after the load, extended or continuous infusion of beta-lactams is recommended. For de-escalation, once the causative organism is identified, change to the narrowest effective agent, with duration individualized to the patient etiology and trajectory. Procalcitonin may be useful in guiding cessation of antibiotics. Second step, resuscitation. Initial resuscitation with crystalloids completed within 3 hours, 30 milligrams per kilogram in most patients. Increased caution in heart or renal failure. Balanced crystalloids like lactate ringer are associated with decreased mortality and decreased renal impairment in critically ill adults. Normal saline is inferior. New data is emerging to suggest isotonic bicarbonate resuscitation may decrease rates of complications such as ARDS and multi-organ dysfunction and hemorrhagic shock, though no clear mortality benefit has been noted. Targets of resuscitation is lactate clearance, normalization, or greater than 20% reduction in 2 hours. Basically, when the lactate peaks and starts to trend downwards, this is a good sign that the sepsis is resolving. If the capillary refill is less than 3 seconds, this is also a good sign. Fluid resuscitation goals in sepsis remains controversial. Recent data suggests that mortality and secondary outcomes are similar between restrictive and liberal fluid strategies. Utilize clinical judgment to prevent volume overload. Assessing fluid responsiveness. So pulse pressure variation is a validated test to see if the patient is responding to fluid resuscitation or not. So essentially, if the pulse pressure, the difference between the max pulse pressure and the min pulse pressure over the mean, if the pulse pressure variation is greater than 13%, the patient is fluid responsive. So another test you can use is passive leg raise. So if you raise the legs to 45 degrees and the patient's pulse pressure increases by 10%, this is a sign that the patient is fluid responsive. If they're responding to bolus fluids and they increase by 10% of pulse pressure, there's another sign that they're fluid responsive. Third medication or intervention that you could do. Vasopressors are used in septic shock. These target a mean arterial pressure of greater than 65 millimeters mercury. Permissive hypotension reduces vasopressor use and may be appropriate in select patients. Norepinephrine, otherwise known as Levo, is the first choice. Vasopressin, known as Vaso, is the second choice when Levo is already used. Epinephrine is used second or third line, and phenylephrine, otherwise known as Neo, is used when there's contraindications to the first 3 options. So, other pressors are dopamine, can be used in cardiogenic shock, and methylene blue can be used in refractory distributive shock, though increased risk of hemolytic anemia in patients with G6PD deficiency or serotonin syndrome in patients on serotonergic meds. Hydroxycobalamin is used in refractory distributive shock, and angiotensin II can also be used. So the fourth intervention or management step is source identification and control. It's important to obtain cultures prior to the antimicrobials. So let me go over this in detail. The order you do is first you do the Q-SOFA score or the SOFA score to indicate whether the patient is septic or not. Next thing you do, get peripheral IV access, draw blood cultures, give fluids, and then antibiotics. So the cultures before the antibiotics is very crucial because this allows you to specify what organism is causing sepsis. If you give the antibiotics before drawing blood cultures, you're likely going to impact the blood cultures and they're not going to be sensitive anymore. In that order, let me just type it out. Peripheral IV access blood cultures, fluids, and then antibiotics. So where to draw the blood cultures? So get at least 2 sets of blood cultures peripherally, preferably from a peripheral vein, and at least 1 drawn percutaneously. Sorry, let me just say that again. So you get 2 blood cultures, 1 drawn percutaneously, drawn from a peripheral vein, and the other one can be from any other site. Only draw cultures from vascular access devices if concerned for catheter-related bloodstream infection. So another thing is identify which conditions require source control. So these conditions include necrotizing soft tissue infection, abscess, cholangitis, cholecystitis, GI perforation and ischemia, pyelonephritis admitted with obstructive renal stone or abscess, empyema, septic arthritis, or devices. Basically, if you have some source of infection that's not going to resolve with treatment, you have to go into that site and remove the source of infection. So once stabilized, there's a low threshold to obtain cross-sectional imaging to identify the infectious source. Now I'm going to pause the video and come back to part 2. All right, hello everyone. This is the second part of sepsis. So other aspects of management. So corticosteroids, the reason for corticosteroid administration is that the rationale is that critical illness affects the HPA axis, may cause relative critical illness related corticosteroid insufficiency. So there is conflicting evidence, but essentially the NN and French trial showed decreased mortality with IV hydrocortisone 50 micrograms every 6 hours, plus fludrocortisone 50 micrograms per day for 7 days in patients with septic shock. Was replicated, but others showed no change in mortality. The Cape Cod trial showed mortality benefit for patients hospitalized with severe bacterial community-acquired pneumonia. In this case, hydrocortisone 50 micrograms every 6 hours or 100 micrograms every 8 hours plus 0.1 micrograms fludrocortisone in septic shock with ongoing vasopressor requirement was indicated. Next thing, AKI. So there's no mortality benefit to early versus delayed initiation of hemodialysis or dialysis, but essentially the continuous veno-venous hemofiltration is one option in which minimizes the fluid shifts in hemodynamically unstable patients. Metabolic acidosis and lactic acidosis. Ultimately, there's a need to correct the underlying etiology, can temporarily solve the condition by using bicarbonate if there's severe acidemia with pH less than 7.1 or less than 7.2 with AKI. And bicarbonate administration is indicated, but remember that for every increase in bicarb, there must be PCO2, which must be ventilated off, which can suppress respiratory drive. So transfusion goal of hemoglobin, 7 grams per deciliter, the same thing as anywhere else. So transfusions is not contraindicated. So interventions without clear benefit, vitamin C, thiamine, and short-acting beta blockers have no shown benefit.